and get started here. I'd like to welcome everybody to Grand Rounds first. If you'll notice the sheets of paper with the QR code sitting on the tables, if you could please scan your QR code and log in, that will help us continue the CME credit, continue the videotaping, and continue the food. So it would be much appreciated. Today it's my pleasure to introduce Dr. Brent McNew. He's, for those of you who don't know him, he is our only pediatric anesthesiologist here at Niswonger. Dr. McNew comes to us from Vanderbilt University, where he attended medical school and completed a residency in anesthesia. He then went up to University of Pittsburgh, where he completed a fellowship in pediatric anesthesiology. Dr. McNew has numerous publications and research quality improvement studies, several dealing with ventilator-associated pneumonia, as well as working with complex heart children who have surgery for other reasons and some of the complications they face. He has numerous research studies that have been published, including perioperative 6-word stories, which sounds interesting. I'll have to look that one up. And several hobbies. He's an avid outdoorsman. Recently hiked up to Buckeye Falls, which is the tallest waterfall east of the Mississippi, right here near Johnson City, and is an unsuccessful turkey hunter. So let's welcome Dr. McNew.
Okay. Do I got to turn this thing on? Does it just come on?
Oh, is the audio on?
Flip it.
All right.
Okay. All right. All right, so like I said, I'm Dr. Brent McNew, one of the staff anesthesiologists here. I also cover Franklin Woods. I'm part of the anesthesia and pain consultants group, and so we don't just cover here. I also go to Franklin Woods and one of the day surgery centers actually up in Kingsport. But we're all part of Ballad Health now. It used to be Mountain States, but anyways, we'll get started. So when I was asked to do this presentation, my first thought was, do I give like a textbook lecture? So I thought, do I give a lecture on the pediatric airway or anesthetic pharmacology or neurotoxicity? That's a hot thing out there right now. And when more I thought about it, those are all things that you would think you would have those questions, and you'd say, well, I have this question, I want to learn more about this. And you would come up with that question on your own, and you know where to go get the answer. There's a textbook. You can go look up a PubMed article. You can look up a meta-analysis. You can get these answers for yourself. So instead, I stepped back and thought about presenting a topic that is more of, you may not have ever thought to ask the question, because you wouldn't know that this is out there, that this is something to look for. So that's more what this is going to be geared to. You will get some practical knowledge out of this, but some also kind of conceptual stuff that you may have never thought of that know that's out there. So the title is Pediatric Perioperative Medicine. I have no disclosures, neither does my wife. So learning objectives. As a result of participating in this, you're going to learn 3 things. First, we are going to talk about the entire field of perioperative medicine, but we're going to talk about a couple of concepts. One's a concept, one I'd actually describe more as a philosophy. The first is the concept of the perioperative surgical home, which is something that's put out by the American Society of Anesthesiology, the ASA. Another one is a more interdisciplinary thing. It's this philosophy called Enhanced Recovery After Surgery, or ERAS. And they're kind of newer components of the field of perioperative medicine. So we're going to talk about them. You'll learn what they are. The second thing we're going to do is something kind of practical. I want you to be in a position as budding pediatricians, current hospitalists, current primary care providers, intensivists, being able to predict which medical comorbidities are actually most important to us as the anesthesia team and the perioperative medicine team, so that you can actually anticipate the necessary preoperative information, diagnostic testing, even therapeutics to better get the patient ready for their surgery as much as can be, to optimize them. And we'll talk about optimizing. That's a key word. I want you to take a keyword to take away from this thing is optimization. And the third thing is probably the most practical point. We're going to talk about this as part of the ERAS. We're going to talk about employing a multimodal pain management approach, which both safely minimizes opioid pain medication, big hot topic out there right now, as well as still effectively treating pain probably better than opioids alone, or leaning so heavily on opioids. So we'll get to that at the end. So what is perioperative medicine? for every organization out there, you can find a different definition. I like the Wikipedia definition, so I started with that. Perioperative medicine is the medical care of patients from the time of contemplation of surgery through the operative period to full recovery, but it excludes the operation of the procedure itself. It excludes the nuts and bolts of taking out an appendix or doing a G-tube or taking out tonsils, the surgical aspect of it. It's all the medical care around it, including anesthesia. But it's not my favorite. I actually decided to personally define it for myself. So I came up with this preparing the presentation. I think of perioperative medicine, it's the application of best medical knowledge from the decision to have a procedure, so similar to the Wikipedia, through the end of the recovery period. So very similar to the Wikipedia at that point. But I actually added the purpose of it. And the purpose in my mind is to optimize the patient for the best chance at the maximal outcome. That's my job as an anesthesia provider, as a perioperative medicine provider. There are many potential stakeholders, services, providers involved in all this. You have the surgical team, you have the anesthesia team, you have the intensivist team. If they're inpatients, you got the hospitalist team. If they're outpatients, you may have the primary care providers that got them in the pipeline in the first place to have surgery. You got to have the nursing staff on board all the way through. You may need supplies. If it's a relatively complex surgery, maybe you need to make sure you got the right vendors bringing the right supplies, the right reps in the OR to help you. So there's a lot of stakeholders involved in this endeavor of perioperative medicine. So the American Society of Anesthesiology, about almost a decade ago, pushing a decade, instead of defining perioperative medicine, kind of passively putting out this nice touchy-feely definition, instead they actually come up with an active model of what perioperative medicine should be. And in the great scheme of marketing, they actually branded it. And so instead of calling it perioperative medicine, they called it the perioperative surgical home. And it's not a building. It's not an actual home. It's not a pre-op clinic. It's a virtual pathway. And we'll talk about that. They just called it a home. I don't know why they chose home, but that's what they did. So it's called perioperative surgical home. I think it goes with, there was the push for the patient-centered medical home stuff with the Affordable Care Act. I think that's where it comes from. I'm not positive about that, but it's where it's a parallel to that. And they define this straight from their website. The perioperative surgical home is a patient-centered, innovative model of delivering health care through the entire patient's surgical procedural experience, from the time of the decision for surgery until the patient has recovered and returned to the care of his or her patient-centered medical home or primary care provider. There's some strategic principles of the perioperative surgical home. Number one, it's patient-centered. For a lot of people, a lot of providers, especially surgeons, sometimes that's a tough one. It's really should be centered around the patient and not the actual hospital or the medical providers. The big component of that is patient engagement, helping the patient, and in our case with pediatrics, the family itself, feeling like they're being engaged, they have agency, that they're participating in the decision-making process, because we know that basically when patients are more involved in their own care, they tend to do better, rather than kind of imposing and just basically telling them what to do. So there's a shared decision-making component. The ASA really pushes that a lot of this be physician-led. Really all of it, they're a very big proponent of any kind of stuff being physician-led. There are other providers out there of different licenses and trainings, and they are important, and they have their roles, and they're critical to doing this too, but really the leadership should be physicians. It is team-based. There's an anesthesia team. There's a nursing team, there's a surgical team. It's really team-based. Fourth principle is it really is evidence-based care. And there's a big buzzword, variability. Reducing unexplained variability, which also reduces complications and rework. And that's buzzwords, if any of you are all familiar with kind of efficiency engineering stuff, that's the Lean Six Sigma Toyota model. A lot of providers, especially older providers, are resistant to that because they don't want to practice cookbook medicine. You've probably heard people say that. At the end of the day, when you actually look at the data though, 90 to 95% of patients have better outcomes if you practice cookbook medicine, if you do the same thing every time. The role of the clinician, where the real art of it comes down, is knowing the 5 to 10% of patients you don't want to do the same thing you always do. That's the art. If you're good at that, that's what sets you apart of being a good provider, is knowing when not to. But most of the time, you should be doing the same thing. And that's part of the perioperative surgical home, is trying to standardize this stuff. It's coordinated care. So we talk to each other. From a medical legal perspective, root cause analysis, anytime there's an adverse outcome, rarely is poor communication not a major part of why something bad happened. So we have to have coordinated care. We have to talk to each other. We don't all operate in little silos, and what happens in the OR doesn't affect post-op, and what happens in the primary care clinic and the pre-op clinic doesn't affect in the OR. We have to talk to each other. And ultimately, we all want it to be safe. So the perioperative surgical home, again, I think of it more as a pathway. It's a virtual home, but it's really a pathway. It's usually procedure specific. In fact, I kind of want it to be procedure specific. It is not a pre-op clinic for every surgical patient that comes through the door. It is you pick usually a common procedure, either a common procedure or a procedure with high morbidity. And you develop a pathway for that particular perioperative event. They encompass many things. There are both inpatient and outpatient procedures, and it encompasses all age ranges, neonatal, pediatric, all the way up through adult and geriatric, adolescents. In actual practice, these pathways are often hard to find. They do exist, but hospitals are often kind of protective of their internal stuff, so they don't always see it published. My home institution, Vanderbilt, actually is publishing a lot of this stuff. They usually call it ERAS, Enhanced Recovery After Surgery, and then they pick a procedure. They're publishing a lot of these right now. They just published one on liver transplants. So they do a lot of liver transplant, but they still don't do that many of them, but they've put together an ERAS pathway for liver transplants in adults. That one is publicly available. They just published it. But not all of them are, unfortunately. But whether formal or informal, these pathways can be developed for any group of patients having any procedure. But again, the low-hanging fruit is always your most common procedures, or also kind of very serious procedures. This is their model. This is the diagram of what this looks like from the ASA. At the top, you can see the leadership. That's who's overseeing this particular surgical home for this particular procedure. And then underneath that, in the second row, between the two people, is the four components, the four phases of the perioperative surgical home. There's the preoperative phase, the intraoperative phase, the postoperative phase, and the long-term recovery phase. You can imagine that's pretty obvious. You can imagine that why those things exist. They all have different components that we could spend all day talking on, all these different things, and we'll pick the most important ones, mostly on the preoperative side, a little bit on the intraoperative side. But there's different components. These things all are important. If you look on the third row, that's the data. If you're going to do a perioperative surgical home, you need to collect data so that you can analyze it. You're going to find things that you're not doing well and you want to make better. You can't do that without data. So that's where the third row comes in, as the healthcare analytics and quality improvement. And then at the end of the day, all this stuff is going to fall flat on its face unless you got buy-in and support from your other departments that aren't exactly always in the OR. So your pathology department, your radiology department, your central supply, making sure you got the supplies that you need up to the OR on time. Your IT people helping make sure you get people scheduled and at the right places at the right time. So there's a lot of other services, ancillary services throughout the hospital that are important to making this work smoothly. So I'm not going to talk about it anymore. We're actually going to design our own going forward. So to illustrate what the Pediatric Perioperative Surgical Home is, we're going to discuss one of the most common procedures here at Niswonger Children's Hospital, the tonsillectomy and adenoidectomy. And we're going to come up with a pediatric surgical home for it and what that might look like. So how does it start? Typically, you have a child who parents report to the pediatrician, lots of sore throats, or maybe they've started bedwetting for the first time and they're tossing and turning and being sleepy at school. Maybe they actually have sleep apnea, or they have both. But some things often frequently coexist. Whatever reason, they get referred to an otolaryngologist. An otolaryngologist begins a surgical workup. Maybe he sends them for a sleep study. Maybe he watches and waits and actually sees how many infections they get. There's different ways to approach it. But ultimately, at the end of the day, they get their data. They present to the parents, your child needs surgery. And the parents and the surgeons make the joint decision to proceed with that surgery. And so at that moment, it's actually when they enter the perioperative surgical home, so they become the little man on the left. And so what we're going to do is just start walking through some of the most important aspects of this. So the first one we're going to talk about is preoperative assessment and triage. First thing that comes to mind around that is comorbidities, other medical problems that patients have, children have. Something to know, something to realize and to take away from this is, in my mind as a practitioner of perioperative medicine, the most important comorbidities to me are the ones that I actually can do something about, okay? The way I always, when I describe that to people, I always describe it in this manner. So if somebody has a child, for instance, it was a premature child and has chronic lung disease at baseline, and it's chronic, and it's stable, and they have bad lungs, there's not much I can do about that. I can't give them a magic pill to make their lungs better before surgery. I mean, if they're having an acute exacerbation of something, sure, I can do something about that, but most of the time I can't do much about it. They just are sick and they have bad lungs. As opposed to something like a heart problem. Let's say they have a congenital heart problem and they're starting to get some pulmonary hypertension from overflow, and we're picking up on that. Maybe we need to fix that before we fix something else. So I can intervene more on hearts. So that's kind of the way to think about that. So I'm going to talk about some of the stuff that I find is most important, comorbidities, because these are the things I can actually intervene on, things that I can do something about. First thing, personal or family history of problems with anesthesia. I'm sure everybody's probably heard of malignant hyperthermia at some point. Really what it is, it's an absolute contraindication to succinylcholine and volatile anesthetics. These are triggers for malignant hyperthermia. So instead of, we do a non-triggering anesthetic, which typically 99% of the time means you're using propofol and some kind of opioid. And you're not actually, you just have the breathing tube in just to basically maintain their airway. They're not being kept asleep by the anesthetic gas that they breathe. How malignant hyperthermia works, it's a hypermetabolic state that's triggered by these agents. There's a receptor in the sarcoplasmic reticulum of the muscle. It's called the ranitidine receptor, and they have a defective mutation in that, and they have a dysregulation of the amount of calcium that comes out of the sarcoplasmic reticulum into the cytosol of the muscle cell, and they get an intense muscle contraction, and then it doesn't stop, and it continues, and it stays contracted. That creates heat, that burns up fuel, that creates CO2 from oxygen, and the cardinal symptoms are eventually get fever, but often the first thing you see is this rapid decrease in CO2 and this rapid suck up of oxygen, and then they start to get hot. So that's malignant hyperthermia, and it's a hypermetabolic state. The important thing about that is it's actually really easy to do a triggering anesthetic these days. We just have to know about it. We have to know if there's a family history. We have to know if there's a personal history, because it does take a few minutes to actually prep the OR. We have to flush the machine. We have to take all the volatile anesthetic things off the machine and flush it out with a bunch of air and oxygen to get rid of any trace down to like less than 10 parts per million of the volatile anesthetics. And we got to get all the succinylcholine out of the room so we don't accidentally pick it up in a syringe swap. So it takes a little bit of time to prep it, so it's good to know that a patient has this before the day of surgery, because we want them to be the first case of the day. We don't want them to follow 2 or 3 cases of the day, because then we got to stop the OR. We got to wait 30 minutes. We have this big delay in the OR while we're getting the room prepped. Whereas if they had been the first case of the day, we could have been prepping it at 6 o'clock in the morning, and they would have started their case on time, and the day goes forward as expected. The second one is pseudocholinesterase deficiency. I don't know if everyone's heard of that. It's a relative to near absolute contraindication to succinylcholine, as well as ester local anesthetics and even cocaine. We'll talk about why. At the neuromuscular junction, you all know this from basic science. At neuromuscular junction, the nerve cell releases acetylcholine that hits the muscle cell, causes it to contract. So that's how we move. A cholinesterase is in the cleft, breaks down the acetylcholine, and that's how your muscle relaxes. Succinylcholine is, if y'all don't know, is actually 2 acetylcholine molecules actually joined together. It's 2 of them. Acetylcholinesterase can't break that down, so it requires this other esterase of the blood called pseudocholinesterase. It has to break that down. What happens with pseudocholinesterase deficiency, we've all probably seen someone get sucks. If you give them sucks with pseudocholinesterase deficiency, instead of it wearing off in about 10 minutes, it might take 6 hours. And so they'll have this prolonged postoperative mechanical ventilation, which is a problem. It's not necessarily dangerous because we can maintain them that way, but it's annoying. If but anything, it's annoying. It's rare. I've actually never seen it, but it is more common than you think. It is something like 1 in 2 or 3,000 people have a problem with it. But I personally yet to have somebody who didn't know they had it. I gave them sucks, and they had a prolonged postoperative intubation. It also breaks down ester local anesthetics, so not lidocaine, but another popular one is chloroprocaine. In some centers, in pediatrics, they get a lot of epidurals, and in those epidurals, they'll use chloroprocaine because it's considered to be safer, because it's much less likely to cause toxicity because it's broken down by these esterases, the blood pseudocholinesterase. If you have a pseudocholinesterase deficiency, you're not going to break down the chloroprocaine, and so you actually go back to being higher risk of getting toxicity because you're using too much. So that's something to know about. And then also, believe it or not, cocaine is broken down by pseudocholinesterase, and we still actually use cocaine at ENT surgery, especially in nasal surgery. They dab cocaine because it acts as both a vasoconstrictor and a numbing agent. So it's still occasionally used. And if somebody has, gets cocaine with pseudocholinesterase deficiency, they're at risk of having an adverse reaction to that and actually getting toxic and maybe having a cardiac arrest from cocaine. The third one is muscular dystrophy. So this is the Becker's, this is the Duchenne's. Those are considered contraindications mainly to sucks, although somewhat to volatile anesthetics. This is why succinylcholine has a black box warning from the FDA. What was happening was you had 4 and 5-year-old boys who had Duchenne's, didn't know they had it. They got surgery. We gave them sucks. And then they had a massive hyperkalemia response, because what happens is when that contraction from the succinylcholine happens, you actually seriously damage the muscle, and it releases a ton of potassium out into the bloodstream, and they can have a rapid lethal hyperkalemia from that. There's also some theoretical stuff out there. There's not great prospective data on it, but we also probably shouldn't be using volatile anesthetics on these kids. It also kind of damages the muscle, but in a much slower fashion. It's not really going to cause hyperkalemia, but it's going to cause some maybe acceleration of muscle weakness in these kids. So probably best to avoid volatile anesthetics in kids who have muscular dystrophies. Not 100% sure about that yet. The fourth one is burns, spinal cord injury, and stroke. These situations are denervation scenarios. Whenever the neuromuscular junction is denervated, there's not enough, the normal amount of signal coming down the nerve axon to hit the end and release acetylcholine across. You have this relative decrease in acetylcholine. The muscle cell on the other side of the neuromuscular junction senses that and starts upregulating the receptors at both the actual junction and extrajunctionally to reestablish that equilibrium and try to grab more acetylcholine. Normally, that essentially is not a big problem unless they get sucks. And then you give them sucks, and you hit these receptors, and they get a massive muscle contraction. They too can get a hyperkalemic response from a massive dump of potassium into the bloodstream, and they can have a similar kind of cardiac arrest from hyperkalemia following sucks. So those are kind of pretty strong contraindications. Another one, the one that actually gets most people these days is actually prolonged bed rest. You see this after, if you take somebody who's been in the ICU for a couple of weeks, been mechanically ventilated, not moving around a whole lot, the same thing happens to them. So giving them sucks after prolonged bed rest could cause the same thing. So these are all things we like to avoid around that. This is the big bane of pediatric anesthesia, is upper respiratory tract infections and how to manage those. So what's the big deal about having a cold and doing anesthesia with a cold? The problem is it increases the risk for perioperative respiratory complications. Those include laryngospasm, bronchospasm. The rest on this list: breath holding, stridor, atelectasis. Atelectasis causes hypoxemia in the PACU. We can't send them home if their sats are 90 on 2 liters of oxygen, so they'll get an unanticipated hospital admission. If they get have really bad bronchospasm, they might make it to the ICU. They could develop postoperative pneumonia, make it to the ICU. They get ARDS. And actually, there's been a few case reports. What they think, there's even now, you used to have a lot of cardiac arrests with inhalational induction with halothane. There's been a few even with sevoflurane now, which was always considered to be much safer. Some of those they think are kids who have a subclinical upper respiratory tract infection, a viral infection, and they have a viral myocarditis they don't know about, we don't really appreciate, and you throw sucks on top of that, their heart stops. So it can actually cause a cardiac arrest in the OR. General anesthesia generally around a cold increases your risk of respiratory complications 2 to 7 times higher. You throw an endotracheal tube, that subpopulation, it's 11 times higher risk of perioperative complications. Age influences the risk. Less than 1 year, highest risk, obviously. Preschool children, intermediate risk. Older, school-age children up to adults, lower risk. Honestly, with adults, I anesthetize adults all the time with colds. Unless they're acutely, severely ill, I anesthetize adults, but I don't do that with little kids. But the management of this, how we actually manage this, is best illustrated by dividing procedures up into elective non-ENT, elective ENT, and then urgent procedures. So managing these colds around elective non-ENT procedures. The textbook answer is you want to delay surgery 4 to 6 weeks. It's not delay a week, it's not put them on antibiotics, it's delay 4 to 6 weeks. That's the textbook answer. The reason for that is airway reactivity induced by the virus. So we've all probably had a cold in our lifetime where we were sick for a week and we got better, except we continued to have a little bit of postnasal drip and cough for a month or two after that. That's that induced viral airway reactivity. We see that. That causes us problems in the OR. So that's where the 4 to 6 week time frame kind of at minimum comes from. But it's not the be-all, end-all, this textbook answer, because there's a lot of other stuff that plays into this. First off, not all colds are the same. There are what I call my red flag symptoms. I always ask these. They're fever, productive cough, malaise, anorexia. If a child has a cold with a fever, most colds don't cause fever. Influenza causes fever, but most other cold viruses typically don't cause a major fever like 103, 104. If they have a cold with a fever, it's a severe cold kind of by definition. And so I'm much less likely to proceed if it was a febrile cold. If they have productive cough, if they're coughing up greenish phlegm, it actually may be a lower respiratory tract infection, more so than an upper respiratory tract infection, which is higher risk than the uppers. So if they're having a productive cough, I might not do the procedure on that. And then the others, malaise and anorexia. If they're, when I went through my pediatric clerkship, one of the first things you learn to do when you evaluate a kid, I'm sure you all know, is sick or not sick. You walk up acutely, it's sick or not sick. Little kids especially will try their best to not be sick. They will want to play, they will want to run around, they will want to eat, they will want to be little kids until they absolutely cannot be little kids anymore. So if your parents tell you, yeah, little Johnny was sick last week and he didn't want to get off the couch and he didn't really eat or drink real well, that's a sign of a more severe cold as opposed to the typical kid with a snotty nose who's actually going out and going to play their usual sports, which does happen. Then there's also the yellow flag symptoms. You can see those. Those are less important, but it's the red flag symptoms. So not all colds are created the same. For me, if a child has confirmed influenza by a nasal swab, by definition is a severe cold, and I will pretty much cancel the case really for any reason, because by definition influenza really has a lot of lower tract involvement. That's why they get post-influenza pneumonias. So even if they weren't that sick from the pneumonia, I don't necessarily trust sometimes the clinical history I get from the parents or what I see in front of me, and I typically will cancel the case unless it just absolutely needs to be done. Age of the child matters. We talked about that earlier, why that matters. It has to do with resistant airflow. So there's the equation of the resistant airflow. It has a lot of stuff about length and all this stuff. Well, the one that changes the most is the radius of the airway. So if you have someone who, if an adult has an airway that would take an 8.0 endotracheal tube and they swell a little bit and now they can only take a 7.0, they're probably not going to notice anything. It's not much of a decrease. You take a baby that normally takes a 4.0 endotracheal tube and they swell and they take a 3, that's a 25% reduction. That is to the 4th power, so that reduces their airflow resistance, increases it by 4 times. So it's always to the 4th power, whatever, it's already the 4th power. So younger the kid, the more this is a problem if they have some airway swelling post-op. History of prematurity. So a kid has a relatively minor cold, but they're a year and a half old and they were born at 25 weeks and they have a lot of chronic lung disease at baseline, I might hold up putting that intratracheal tube and doing that surgery today. But at the end of the day, also type of the airway required matters. Sometimes we do anesthetics with just a mask. That's our typical ear tube approach. Mask, an LMA, some of y'all may have seen it. I call it a mask on the end of the stick when I describe it, but that's essentially what it is. You stick it behind the tongue, and it doesn't actually go through the vocal cords. It just kind of sits outside of them in the mouth, in the back of the throat, and allows them to basically have full general volatile anesthetic, but they breathe it through that, and then everything actually passes through the vocal cords, and it's actually a pretty stable airway. But the only thing it doesn't do is protect you from aspiration, and even then, it kind of sort of does. You can do a lot of cases with an LMA, and then there's the endotracheal tube. In progressive order, those are more stimulating to the airway, more likely to cause laryngospasm, bronchospasm, or one of these problems. So I might be more likely to proceed with the case if they've had an LMA, if they're going to manage it with an LMA or a mask versus I'm putting a breathing tube in. And then there's always the parental considerations, and these are sometimes the hardest thing to manage. For me, they're never the be-all, end-all, but it's for kids that are on the fence. Often the parental considerations will come into play. Kids have families. Parents work, parents take time off from work. They have siblings that need child care. They maybe have called a relative up to take care of the kids while the kid's in the hospital, or it's a big surgery and every relative they've got's come into town, to see them through the surgery. It becomes problematic if you're kind of canceling the case otherwise maybe you actually could go through with it, or at least a reasonable person would maybe pursue the case. So it's something that comes into play. If it's really hard for them to get off work, maybe rescheduling this is going to be hard. Maybe you do have to take that risk. And in that case, you usually just talk to the parents, and y'all kind of have to come to a mutual decision a lot of times around that. Travel, if they were recently in another country, maybe it isn't a cold. Maybe it's something weird we actually should stop and think about. The other is tobacco use, which we're going to talk about in a little while as well. So the next one, elective ENT procedures. This is your ear tubes and your tonsils, the thing we're talking about today. So in practice, we have a much higher threshold to cancel the case of this. We more likely will proceed. And the reason for that is the vicious cycle. You can kind of see on the side here. You have kids, they're frequently sick. There's rarely are you going to find a time, a 4 to 6 week window, where they're not sick. And they're getting sick because they have this reservoir, this immune dysfunction regarding their tonsils or the fluid in their ears that's causing them to get sick. And the only treatment for that is surgical. So it just keeps spinning until some point you sometimes have to take the leap, even with them having a cold, to fix them. The nice thing about ear tubes is we do it with a mask, because it's not very stimulating the airways. It takes about 5 minutes, and even really sick kids actually can get ear tubes and pretty much do okay. Tonsils are much more problematic because they have to get a breathing tube to protect from bleeding during the case. So it's a little more problematic, but at the end of the day, it's an individualized risk-benefit analysis for each patient to decide whether or not they go forward. Most of the time, personally for me, unless they have an active febrile cold, I'll proceed. If they're 103 and look sick, I probably will cancel them and maybe delay them a week or something, just because they're going to need it, get it done, and you're not going to find a 4 to 6 week window. But it's, that's the way that works. The final one, urgent procedures. Some kids got appendicitis. Basically, we always proceed with the surgery. It is still an individualized risk-benefit analysis, but in practice, you almost always proceed. Typically in those scenarios, the risk of delay is higher than the risk from the cold. So that's typically for urgent procedures. If you wonder if the kid's in the hospital and needs something done but they have a cold, they're pretty much going to get it done. So big other takeaways from this around colds. The biggest one, kind of a pet peeve of mine personally, is these are viral illnesses. You all know that these are viral illnesses, so I don't have to tell you all that. But it's still at least about once a week, especially in the winter. I have a patient show up for surgery a week before they come down with a cold. They went to a primary care provider, an urgent care clinic somewhere. They got put on antibiotics for their viral cold, and the provider told them, oh, you'll be able to have your surgery now that you've had your antibiotics. And at the end of the day, antibiotics have zero effect on viral illnesses. They have zero effect on the airway reactivity following a viral illness, so they have zero influence over whether or not we would proceed with surgery. And that puts me in a situation on the day of surgery being the bad guy and upsetting these parents who thought they were going to be able to have their surgery and took time off from work and were told by another healthcare provider that they would have their surgery, but I have to tell them no. So know that happens. Try not to do it. But it does happen frequently. The other one is another one, streptococcal pharyngitis. This comes up a lot. There are no guidelines I am aware of how to manage this. This is my approach. It seems to have worked well so far. Streptococcal pharyngitis is a bacterial infection, but it typically doesn't involve much airway structures. It involves the pharynx and the tonsils. It really doesn't cause that much airway reactivity as compared to a true viral cold. So typically the way I handle this is finish your antibiotics and reschedule at convenience. I don't want to, if somebody is 2 days into their antibiotics, I don't want to maybe instrument their airway and cause worse sore throat, but let them finish their 7 to 10 day course of antibiotics, however long you're doing these days, just finish the course. Gastroenteritis is another one that comes up. Now, the key on that one is sometimes some colds cause gastroenteritis, but if it's isolated gastroenteritis, this applies. Again, there's no guidelines. This is my approach. My biggest worries are dehydration and aspiration. So if they have gastroenteritis, usually that means there's some slowing down of their gut, and they've got fluid sitting in their gut, they're at risk for aspiration. I don't want to put them to sleep unless I absolutely have to. They also may be dehydrated from throwing up and having a lot of diarrhea. That causes them, upon induction with vasodilation, blood pressure to drop. So my typical approach to that is delay a week after the resolution of symptoms, especially for nausea and fatigue, because that's the most indicative stuff around dehydration and risk of aspiration, so delay a week. Parental smoking. The perioperative period for both adults, and often many adults will quit smoking around the perioperative period. This is a wonderful time to kind of improve the health of the entire family by advising parental smoking cessation. But it doesn't usually work very well. Parents are, adults are very addicted to their nicotine, and it's hard to get them to stop. But it would be a good time to maybe get some motivation to get them to stop. When I ask parents this during my preoperative interview, I usually frame the question very specifically: does anyone in the home smoke? What they hear is, does anyone smoke in the home? And so they will tell me, well, I smoke, but I only smoke outside. In the OR, anecdotally, I cannot tell the difference between the kids whose parents smoke inside and smoke outside. It comes in on their clothes, it comes in on their hands, and they all act the same in the OR. So it really doesn't matter, and I tell parents that. But the problem is the day of surgery is kind of too late. We know that parental smoking is a significant risk factor for respiratory complications. What we don't know, and I looked around for this, I couldn't find an interventional prospective study on this. And so it's a research project out there. If anybody ever wanted to do it, I bet you would get published in a pretty high journal if you did this. We don't know that if you made some kind of intervention with parents weeks in advance and got a significant percentage of them to stop smoking in the weeks leading up to the procedure, will the kid have fewer respiratory complications? We don't know that. Or at least I couldn't find a study for that. So a research project plug out there. But given what we know in adults, it probably would. It's a quality measure for us in anesthesia that we advise patients not to smoke on the day of surgery in adults, and that they don't smoke on the day of surgery. That's a quality measure. Why? Because we know that even less than 24 hours not smoking, or around 24 hours of not smoking, reduces nicotine in the blood, which reduces vasoconstriction. They heal better. There's a lot of benefits. And then as you keep going further and further out not smoking, there's improvement in respiratory function. The ciliary bodies in the lungs actually start moving mucus better. They start to regrow. So there's benefits no matter how long you stop smoking is what it looks like. So it'd probably be the same way in kids, but I don't know in kids so much if you stopped them 24 hours if you would get much bang for your buck. You'd probably get more bang for your buck if you got them to quit 6-8 weeks in advance. So, and then that kind of comes down to the time frame for surgery. So, the rest of the stuff, congenital heart disease, bleeding disorders, genetic syndromes, diabetes, all around that stuff, the big thing is we need a diagnosis a lot of times. A common scenario is a kid shows up for surgery and the parents say, well, yeah, he has a murmur. I personally am terrible at hearing murmurs, but the parents will say somebody's told them they've heard a murmur before. And then I ask, have they ever had an echocardiogram? Have they ever had that murmur worked up? No. And so generally, I know that if it's a 3 or 4-year-old, if they've got a murmur, probably worst case scenario, it's probably an ASD or VSD. It's probably, or it's an innocent murmur. Because if they've got something more significant than the ASD or VSD, they probably are symptomatic from it. But still, it'd be nice to know that. So bleeding disorders is another big one. This is a common story. Kid shows up for surgery and they tell me, well, I go, any history of bleeding disorders? And they say, no, we don't know about anything, but he really bled a lot during his circumcision. I don't know what that means. And I go, well, did you ever go see a hematologist? No. So I've got this kid showing up for a tonsillectomy and has never been worked up for potential bleeding disorder. And the most common one out there actually is von Willebrand's disease. It's like 1 or 2% of the population has von Willebrand disease. And that can be a problem during tonsillectomy. So if we know they have this diagnosis, we can, or at least suspect a diagnosis, send them to a hematologist, get a diagnosis, because all these bleeding disorders have treatments. They'll prescribe us. They basically tell us exactly how many units to give, how many hours before surgery, and it's seamless, and it really improves their outcomes because then they don't bleed. But if I don't know the diagnosis, there's like, for instance, if von Willebrand's disease is a good example. There's 4 types. 3 of the types, you give them DDAVP, they improve. The 4th one, you give them DDAVP, they get worse. So I can't just, if they just tell me they got von Willebrand's disease, I can't actually automatically give them DDAVP. So I actually need to know the type. But really, kind of outside of the stuff I've talked about, for most other organ system pathology, it's great to know the diagnosis, it's great to know the severity, but there's not a whole lot I can do about it. They got bad liver, can't fix their liver. They got bad kidneys, can't fix their kidneys. There's just not a lot I can do about those things. But the thing about that is, it's great to know those things because I still need to have a conversation with the parents, and I basically put the child's comorbidities into 2 columns. These are the things we can optimize that we can do something about, and these are the things I can't. And you need to know that these are higher risk and these are the risks for your kid, and we have to just accept the risks to go forward with the procedure. Do you understand that? And so it's important to have that conversation ahead of time. Triage, tonsillectomy. So if you're busy ENT practice, you got 30 tonsillectomies you need to do, but you only got 10 spots that week, you may have to pick the most urgent ones. You may have to think about the location of the surgery. Often that's driven by post-op requirements. Believe it or not, there are kids out there with obstructive sleep apnea so bad that they need ICU care post-op. We don't see a ton of those here, but every once in a while, one will come through. They're so sensitive to narcotics post-op. But you can't do, if they need inpatient care, if they're under age 3, they have sleep apnea, they don't need to be done in an ambulatory surgery center. So we got to think about that during triage. And again, back to having some of these things like bleeding disorders, a preoperative specialist referral is important for management, and that might occur during the triage phase. Family education is another important thing in the pre-op situation. We want to be able to communicate to the family. And it's actually important to communicate to the child. So kids, believe it or not, know more about what's going on than you often think they do in surgery. They know something's up, especially as they get around school age. It makes them anxious to not feel like they have a say in the matter, they feel like something's being withheld from them. A lot of them want to know what's going on. They want to feel like they have some agency. And so it's important in an age-appropriate way to actually get them involved too. So maybe, a school-age kid's having a lot of anxiety, maybe the answer is bringing them in a week early and have them see the OR and see the anesthetic mask and meet the nurses and, meet with child life, and maybe that will alleviate anxiety going ahead of time. Some places give kids a book, and it walks how the operative day is going to go, and they read it ahead of time. So there's different ways to approach that, but the big thing is whatever you're doing, we have to communicate to these kids in an age-appropriate way. There may be home medication management stuff we need to do. Some things we want them to take, some stuff we don't before surgery. In the congenital heart disease world, we typically will see a lot of hypotension if they take ACEs or ARBs as management for their congenital heart disease, and we put them to sleep and they took that ACE or ARB the day of surgery, we'll see pretty bad hypotension on induction. And it's really resistant to our normal means of fixing them. They don't respond that well to fluid. They don't respond to phenylephrine. They don't even really respond that well to epi, but the only thing it will respond to is vasopressin. But what we found that is if typically for most people and adults as well, if you hold that ACE or ARB the day of surgery, they only had it the day before, enough of it's out of their system, you kind of fly the airplane in through the needle. They don't really get they're not having a lot of hypertension because all the ACE inhibitors gone, but they're not having hypotension because we had it the day of surgery. So that's an example of that. The next big thing to talk about is MPO requirements. This is one of the most mischaracterized, misinformed, misused things in the perioperative medicine world. For the better part of 2 decades, the ASA guidelines have said 6 to 8 hours for solids, 4 hours for breast milk, 2 hours for clears. That has been well before I was even in med school, the rule. We still have people across the country, anesthesia providers, other providers, that either don't know that or know it and don't care. And they put, especially in kids, it causes a problem. So to describe it better, it's 6 to 8 hours for solids, non-human milk, and formula. The 6 to 8 hours is really a fudge factor there. It has to do with fat content. So cheeseburger, pizza, biscuits, and gravy is 8 hours because it's a high-fat meal. We all have had it. You go to Thanksgiving meal, you have all that gravy, you're full the rest of the day. But you get up in the morning and you have a bowl of cereal, you're hungry 3 hours later because it empties out your stomach faster. So that's where the 6 to 8 hour thing comes into play. There aren't a lot of adults out there drinking breast milk, hopefully. This really applies only to kids, but 4 hours actually for breast milk. Human milk empties out of an infant's stomach faster than formula does. So we allow actually 4 hours for breast milk. But the real big one that's the source of all the problems is the clear liquids. It's 2 hours. And the reason for that is we know that making an active effort to decrease the clear liquid fasting time to closer to 2 hours has been shown to have multiple improvements in outcomes for kids. When you test their urine, they have fewer ketones because they're not starving. They're getting sugar, and so they're not actually in that starvation phase. They're not turning into this catabolic phase that happens when you start withholding food and water from little kids who are growing and using energy on a high rate basis. But it also happens with adults as well. Because they're well hydrated, we don't have hypertension and induction when we vasodilate them and give them medications that also have some myocardial depressant stuff. They'll hold their pressure better. We have to stick them fewer times to get an IV because they're well hydrated. They actually have less postoperative nausea and vomiting after the surgery because they've had a little something in their stomach and it's not so dried, and they'll actually have less nausea and vomiting. The biggest one probably honestly is increased parental satisfaction. I've experienced that myself. You take a child who doesn't understand what's going on and when you withhold food and water from them, they get very irritable. And you have the right combination of parent and child, irritable child and parents running thin on some patience, it can be a volatile experience for this family to withhold food and water from this child, and it's completely unnecessary. It's completely unnecessary to go beyond 2 hours for clears. But routinely, pediatric patients across the country are routinely subjected to fasting times longer than the above guidelines. Anytime they look at it, it pushes out to like 12 hours. It's an order of magnitude more likely that a child will have fasted too long than not long enough. And in fact, to even give more safety around this, the most recent guidelines, MPO guidelines, came out last year in March from the ASA. Rumor that I heard at a conference, it actually almost went to 640, not 8642, in kids. And the reason for that is there's building studies out there where they give healthy kids, they give them fluids, they put their belly with an ultrasound and look at the gastric volume and how fast it decreases over time. And the half-life of a clear liquid in a child's belly is about 12 minutes. And it's gone within 30 or 40 minutes. And so what the 640 means is basically clear liquids until walk into the holding room, and then we stop the clears. There are centers that have actually moved towards this. What I learned at the conference, at least in some departments at Boston Children's, they are 640 now. It is not 2. Now they don't have the national guidelines to back that up, so they are taking a little bit of a risk when they do that, but they're doing it as far as I know they're not having problems, and they're doing it now. But the rumor was they almost switched to this with this most recent iteration of the guidelines, but what they ultimately decided is we don't adhere to the current guidelines we have very well, so rather than making a change, let's actually promote adherence to the actual guidelines. So that's kind of the push right now, is to actually adhere to the current guidelines we have, and then maybe the next iteration they may promote 640. So let's talk about intraoperative management. So this is the philosophy I was talked about, enhanced recovery after surgery, ERAS. Again, it's a philosophy. It started actually in adult colorectal surgery about a decade ago. Instead of looking at the surgical experience in these kind of discrete, in the moment decision making, like I have hypotension, I want to fix hypotension, or this or that, they started actually expanding their vision, their perspective to actually think about the recovery period. And they made their philosophy, the guiding perspective is to manage the patients in such a way to actually improve their postoperative recovery profile. That's the goal. You want them to get well faster and out of the hospital faster and back to their job or back to school or whatever as fast as possible and in the safest way possible. So they started this adult colorectal surgery, and there's a lot of, with adult colorectal surgery, there's a lot of components which wouldn't apply tonsillectomies and adenoids. The biggest ones that would apply probably are pain control and IV fluid management. So we'll talk about those a little bit. But there's a real foundation out there. It's called the American Society for Enhanced Recovery. And they are pushing these, and they're being developed now for other procedures more than just adult colorectal. We're seeing it in kids, we're seeing it in adults. Again, I told you with liver transplants, they're doing an ERAS. Every time they make an ERAS, and I don't know so much if that's just because they're standardizing stuff versus actually the care they're implementing, but every time they do one of these and they look at it, they're seeing reductions of days in length of stay. They're seeing reductions in days of mechanical ventilation. They're seeing reduction in days of time in the hospital. So it works and it saves money. And it's really usually pretty easy things to do that aren't really expensive. So, but we know that better pain control by utilizing multimodal analgesia leads to less nausea, vomiting, less ileus, more ambulation, less sedation, respiratory depression, all important things around tonsillectomies and adenoids. And also kind of restricting IV fluids. Kids should be able to drink post-op. For tonsils and adenoids. You shouldn't be withholding, so you should be encouraging oral intake. You really should not be hooking the IV up at all and make them want to get thirsty and drink. So, like I said, higher quality, less cost to the healthcare system. Every time they look at it, it's good. And it actually increases patient parental satisfaction because they feel like they're getting well faster. They're seeing faster results, and so they actually like what's going on. So how would this look for a pediatric tonsillectomy and adenoidectomy? Opioids are the devil. We probably still need a little opioid in tonsils and adenoids, but just a little. We probably need some, but not a lot. But they really are the devil. They're often necessary to control postoperative pain, especially with TNAs, but they are the source of the majority of problems in tonsils and adenoids. So it's a pick your poison thing. It's the old thing, it's the difference between a poison and a medicine is the dose. If you utilize opioids as I think of pain, I guess I should step back. I think of pain management like a birthday cake. If you utilize opioids as the cake, the actual cake underneath, and not the icing, you're going to have problems. It should be the other way around. You should be using other agents as your cake, and opioids should be your icing on top of the cake. If you utilize opioids as your main pain management strategy in tonsils and adenoids, you're going to have oversedation frequently, portering, pushing into dangerous respiratory depression. If they go home, it'll happen at home, and sometimes kids die from this at home. They're found unresponsive and dead. That's why no longer is Tylenol codeine black boxed for tonsils and adenoids in kids. That's why, because of the differences in metabolism specifically, but we see some differences in metabolism, things like Lortab and oxycodone too. So it's not quite as pronounced as the codeine, but it does happen. We know, this is very well known, kids with severe obstructive sleep apnea typically require a 50% reduction in opioid and benzo requirements due to sensitivity in the mu opioid receptors. We know that, severe. Now, what we don't know is if they have mild or moderate, how much you actually need to reduce from that standpoint. But we know specifically if they're classified as severe, it's a 50% reduction. And this doesn't change in the PACU. This takes weeks to months because this is a biochemical problem at the cellular level dealing with the mu opioid receptors. It takes weeks to days to weeks to actually start to change. So if they are admitted overnight for following a tonsillectomy and adenoidectomy, it's still there. Even though they may not have the sleep apnea quite so bad, although there's some debate out there whether postoperatively if their sleep apnea actually gets worse because of swelling. But they may not have the same mechanical stuff going on, but they definitely still have the biochemical and it lasts for a while. If you give a lot of opioids, you're going to have increased ileus and constipation, which is a universal side effect of opioids. That's going to cause postoperative nausea and vomiting, which is going to decrease your oral intake. But also, if they're taking a lot of opioids, they're going to get sedated. Sleepy kids throwing up don't drink a lot. And we know that, I actually asked one of our ENTs here, he asked how often do you have kids readmitted for dehydration after TNA to the ED, and they say about 2 a month. Get readmitted because they're not taking proper oral at home. A lot of that's because they're throwing up, because they're sleepy, because they're taking opioids, and they wind up getting dehydrated. So What can we do instead of that? So I threw this in at the last second. This may not even be. I don't know if y'all had handouts or not, but this is I actually threw this in this morning. I hate Lortab, and this is why. So we have a love affair with Lortab at this institution. My department has a love affair with Lortab. They've been using it forever, but it has problems, and here's why. Why not use it? Because there isn't. And then they'll ask, well, why? We'll use it because it has Tylenol in it. Well, if you actually do the math, there isn't very much Tylenol in it. You're just adding this agent that could have toxicity, but it's not being effective because you're nowhere near the effective dose. If you do the math, the Lortab we have in this hospital, and this is pretty much everywhere now because the FDA mandated, I think back in 2011, that all formulations of Lortab per unit dose can have no more than 325 milligrams of Tylenol. The one we use here is 7.5 milligrams of hydrocodone with 325 milligrams of Tylenol per 15 milliliters solution. If you do the math, we dose it based on hydrocodone, which is 0.1 to 0.15 mg per kilo. So we take a 25 kilo kid, so a standard school age kid. That's going to be 2.5 to 3.75 milligrams of hydrocodone. That's going to be 5 to 7.5 milliliters of elixir. Now you know how much Tylenol they got, 108 to 162 0.5 milligrams of Tylenol. Do the mg per kilo, it's 4.3 to 6.5 milligrams per kilo per dose. That's not even in the effective range of Tylenol. So now you've given them this Tylenol, and you're introducing into the mix, which limits further use of Tylenol, and it's not even working. It's doing nothing for you. So that's why I hate it. Both institutions I trained at, both Pittsburgh and at Vanderbilt, we do acute pain service rotations where we'll spend a month doing acute pain. And we get consults where people want the services, a lot of times it's orthopedics. They'll say, we have this patient, they're a chronic pain patient, we're having trouble controlling their pain post-op. We'll get involved. Both institutions, both of them taught us, the first thing you do is stop Lortab and Percocet. That's the very first decision. If they are on those, stop those things. Because what you need to do is actually split those things up so that you can maximize your Tylenol to reduce your opioids, because that's your key. So again, that's why I hate Lortab and I hate Percocet, but I love oxycodone. I would probably like hydrocodone if someone actually manufactured hydrocodone by itself, but actually I'm unaware of any hydrocodone actually manufactured by itself. So you're kind of stuck with oxycodone. If you have an oxycodone allergy, you may have to use hydrocodone because you don't have a choice. So that's the situation where 90-95% of the time, doing the cookie cutter anesthetic works, but you got to know when not to. So how do you treat post-op TNA pain without opioids? It can be done. In fact, a lot of places are moving towards it. The big one, the cake is acetaminophen and ibuprofen. Both these agents, they're better together than either alone. They have synergistic effects. They're at least as good as, but actually most studies say they're better at pain control than actual morphine and opioids. They have significantly less sedation because they don't cause any sedation. They don't cause any respiratory depression. You don't get nauseous. Post-op nausea and vomiting does not occur with Tylenol and ibuprofen. The source of the source of the majority of post-op nausea and vomiting is opioids. It's not the anesthetic gas. Some people it is the anesthetic gas, but most people it's the opioids. And we know that there is a clear linear reduction in post-op nausea and vomiting if you reduce per milligram the amount of opioid they're giving them. It doesn't matter the route, it just matters the total dose. More oral intake, less dehydration if you use acetaminophen and ibuprofen because they're not sleepy and they're not throwing up. And again, that's a major driver of post-op readmissions that actually has a potential to reduce. If they bleed, you can't fix, there's an inherent rate of bleeding that's kind of stable no matter what you do. You can't really maybe decrease that. But if they're getting readmitted for dehydration, that's something you can fix. But you ask some ENTs and they're going to freak out over ibuprofen and bleeding. And let's talk about that. So since 2011, ibuprofen has been explicitly endorsed as safe by the American Academy of Otolaryngology Head and Neck Surgery. That's the big society of ENT in America. It's been explicitly endorsed as safe for the better part of a decade. We still have ENTs in this area who will not allow you to use it, despite it's being used. There are places in the Tri-Cities. There are ENT providers in the Tri-Cities who do outpatient ENT. I work with them. They don't even send their kids home with opioids. They only go home on Tylenol and ibuprofen, and they are not having bleeding problems, and they're doing just fine. And they don't. And I actually am able to manage 50% of them without even getting any opioids during the case. So by using Tylenol and ibuprofen. So it's rising in children's healthcare facilities. I asked what they're doing at Vanderbilt since I left. They weren't really using it much when I was at Vanderbilt there. That's their go-to now. They get Tylenol, they get ibuprofen. They're really getting no opioids. Maybe a few doses for the acute pain, but that's it. So practical regimen for pain management. And this is not just for tonsils and adenoids. This actually works for a lot of other stuff too. In fact, this is my foundation. If I get asked to help with pain management in a kid or even really an adult, this is my first move every single time. So what I do here as much for the ENTs that will allow me to do it. In the pre-op room, they get acetaminophen. They get a full dose. I push it as close to 15 mg per kilo as I can get, in a kind of a round number, so the nurses aren't trying to figure out the quarter cc that make it. So I'll usually do a whole number, but somewhere between 10 and 15 milligrams per kilo, and they get that Q6 hours. Scheduled. That's the key, is scheduled, not PRN. You want them to get that every 6 hours around the clock. They don't have to ask for it. And you do that for 7 days. And then after 7 days, you can switch to PRN. For ibuprofen, it's 5 to 10 milligrams. You all know the dose, every 6 hours. Scheduled. They don't ask for it. They get it at the same time as Tylenol. You always keep it in their system. And you do it for 7 days. And we'll talk about the 7 days where that comes from. And then finally, they may need a little opioid. I'm not going to say that you shouldn't ever send them out with opioids. Some people, like I said, there's practices in the Tri-Cities already that they don't send them home with any opioid prescription, so it can be done. But I do see some kids from time to time, especially older kids. Teenagers tend to be a little whiny as opposed to a 3-year-old. They may still need some oxycodone to get them through it. But I can do a reduced dose. The dose of oxycodone is 100 mics per kilo. I can usually get by with 50 mics per kilo. And you do it for 7 days. Where does the 7 days come from? It's this chart here. Actually, do I have to use this thing? No, it's not. You can see this chart here. This is a graph of, the blue line is pain scores by postoperative day for a tonsillectomy and adenoid in a kid. The red line is the inflammatory response to the tonsils and adenoids coming out per postoperative day. So, and the gray bars I actually added, the gray bars are the times when they bleed. Kids don't have a tonsil hemorrhage at day 4. They have tonsil hemorrhages at day 8 through 10, sometimes day 7, but that's when they bleed, and that comes from the scab falling off. So, and they also bleed immediately. There's the immediate bleed, they define that as the first 24 hours. Kids that have an immediate bleed, they bleed in the first hour. They bleed in the PACU. I mean, that's when they bleed. And so, in that scenario, and you look at these graphs, the pain obviously is worse right when you take out the tonsils, and then it gets better over time. But the inflammatory response is increasing, and it peaks at about day 5, and then you have this bimodal peak in the pain, and then it rapidly comes off. By day 7, probably don't even need this stuff anymore because their pain score on average is a 3. And so that's where the day 7 comes in. And then on top of that, at day 7 through 10 is when the bleed risk goes back up. So if you could get off the ibuprofen, there is some thought out there. There's a recent study that's actually just published this month that I found when I was working on this presentation in the laryngoscope from CHOP. It's a before and after study regarding around these 2011 guidelines. They implemented somewhere around 2012, 2013. They started actually using ibuprofen at CHOP, and they had a wealth of data pre-ibuprofen. They added ibuprofen to the mix, and then they started collecting prospective data after that, and they looked at it. And there was about 6 months into it, they had a freak out. The ENT surgeons said, oh my God, we're having so much bleeding, we're having so much bleeding. They actually went back and looked at the data, there was no increase in bleeding. They just remember the bad ones, but they were probably going to bleed no matter what. And so there was no increased risk, and so that was their takeaway. But there seemed to be maybe, in some of the literature, and in this study as well, maybe if they're older than 12, they have recurrent tonsillitis, maybe a small increase, but we're talking less than a % increase. And so is it a % increased risk in having a bleed worth the respiratory depression? And that's a debate to have. And there may be a little increase in the severity of the hemorrhage if they have it. There's a little more risk of having a transfusion if they actually have a hemorrhage, if they're on ibuprofen when they hemorrhage. But that's why you stop it at 7 days, because ibuprofen, even if you're on it for days, the antiplatelet effect is out of your system in no more than 24 hours. So if you stop it at day 7 and they typically bleed day 8 through 10, ibuprofen is going to be gone. So if they bleed, they're not going to be at risk of a worse hemorrhage. So that's where the day 7 comes from. So it actually, serendipitously, the timing works out like perfect to do it this way. Finally, postoperative nausea and vomiting. We talk a little bit about that and some of the other agents that we use in tonsils and adenoids that enhance the recovery after surgery. One is dexamethasone. 0.5 mg per kilo is, I believe, the actual quality measure for ENT surgeries to document that was given intra-op. It helps with the inflammatory response, reduces pain. It actually, and for us, even 0.1 a dose, it'll actually reduce postoperative nausea and vomiting. So it has a lot of uses. We give it to every tonsil. I love dexmedetomidine. I use it daily. I learned it was something I learned to use at Pittsburgh. it reduces emergence delirium in kids. You take kids that have a sevoflurane anesthetic, which is our go-to anesthetic in kids. If you don't give them dexmedetomidine, 1 in 3 of them will have severe emergence delirium on wake up if they're preschool kids. 1 in 3. You give them Precedex, it drops to about 8% from 33%, and they sleep for 45 minutes, and they breathe, and they don't have to be on oxygen, and they sleep, and you poke them, and they wake up and say, "Where's mommy?" and they go home. So it's great. And you can push it, you can bolus it. You don't have to infuse it on kids. You can push it like a fentanyl. Adults, you can't do that. They will have some hemodynamic effects, but the kids, you can push it. It reduces opioid requirements, and then by result of reducing opioid requirements, it reduces post-op nausea and vomiting. So it's and it's actually been specifically studied in tonsils and adenoids. There's multiple studies out there, and it's wonderful in that setting. And then Zofran, of course, we all know that's your workhorse for post-op nausea and vomiting if they're actually having it. So, bottom line summary statement: tonsils and adenoids. If you treat their pain without making them throw up or be sedated, they will breathe and stay hydrated, and leaving you only to deal with the inevitable post-tonsillectomy hemorrhage, which you aren't making worse. So, these are my references. Anybody wants them, I can send them to you. But that's my presentation, and boy, I just nailed it. Questions? Yes.
I thought that was an awesome presentation. I just had a quick question about the clear liquids. Just a question that comes up a lot of time on wards is if we could give medication with clear liquids as well. Is medication generally considered a clear liquid?
No, medication doesn't count. A sip of water, we do it. It's one of the other reasons we know clear liquids don't matter is we routinely give pills with a sip of water in the holding room 10 minutes before they go back for surgery. So
medication is always okay to give.
Medication is always okay to give before surgery. The risk of them missing a medication they need is worse than the risk of them aspirating the pill that's already dissolved in 10 minutes. So as long as it's just a sip of water, I mean, you don't want to give them 12 ounces of water to take the pill, but a teaspoon of water to get the pill down is okay. The bigger problem, the one that I actually run into around that scenario is people that tell me they can't take pills unless they have it with applesauce. That one, I can't let you have applesauce right before surgery. So that one, we kind of have to come up with an alternative plan. So, yes?
I would say for like liquid medication too.
Yeah. I give, for like pre-med, I give Tylenol and Versed. For the younger kids, that's elixir, so they'll get the Tylenol. The Versed only comes in an elixir, and the Tylenol, I'll do elixir too. But older kids, I'll give chewable, but I mean, they'll get 2 elixirs, sometimes within 20 minutes of going back. So, yeah, so elixirs count as well. They really don't. Elixirs don't count at all. They don't factor in, so.
Thank you so much for the presentation. I really appreciate the pain management talk, especially. Did I hear you say correctly that you recommend Tylenol and Motrin be given at the same time each day? We sometimes stagger it to control fevers and things like
Correct. You could stagger it. The reason I would say give it at the same time is because you're giving it every 6 hours, and if you got a kid that's trying to sleep at night, do you want to wake them up to give them a pill at 3 o'clock in the morning? You could stagger it. You absolutely could do every 6 hours, but have them alternating every 3. You're still going to get the same amount of medicine in them. It's just being staggered. You could certainly do it that way, but it just means you may be waking the kid up in the middle of the night to give them a drug. That could be worth it. That may not be worth it. That's a decision to make as a clinician. But so, other questions?
You mentioned obstructive sleep apnea is a condition where you probably need reduced opioid doses if you do give opioids. Are there any other common conditions that you know of where it's a similar case?
Yeah, probably the biggest one that comes to mind when you is kind of the cerebral palsy, cognitive function, pharyngeal dysfunction, kids that can't swallow. Those kids, they do not tolerate opioids very well. Just a little bit of opioid with them and they're snockered and they'll aspirate. I mean, so they don't tolerate it for a different reason, not so much for sleep apnea, just neuromuscular mechanics, and their brain is not completely normal to start with, so they're exquisitely sensitive. So for those kids, especially with like Dr. Green's patients, we started doing epidurals. A lot of his patients, especially the ones we do the epidurals for, are kids that have cognitive dysfunction, cognitive handicaps, or neuromuscular handicaps. And so for them, an epidural really makes a lot of difference for them because you don't have to give them any opioids. You don't give them any. And they don't care that they can't move their legs. So it actually does really well for them. So, other questions? I don't worry about it in kids. I really don't worry about it in adults either. If they have a history, I mean, that's a you got to know your contraindications to your drugs. So a contraindication to an NSAID is peptic ulcer disease history. If they have a peptic ulcer disease history, that's a time to be a clinician and say, maybe I don't need to do what I normally do. So maybe I don't do ibuprofen in that scenario. But most kids don't have peptic ulcer disease history. It's really an adult thing. But I guess it's possible. So, or they have, and here's another one that comes up frequently, liver problems. So at Children's Hospital Pittsburgh, we gave IV Tylenol to post-op liver transplants day 0. We just gave them a reduced dose. We gave them like 7.5 to 10 mg per kilo. We had no problems. You just have to give them a reduced dose because they got a brand new liver that's working, should be working well. The Tylenol is not going to be their problem if their liver's not working well. So, but if they have if they at baseline have some liver dysfunction, typically they still do just fine. We typically say for adults with cirrhosis, you can still give them 2 grams a day. So it's a half. We say for normal adults it's 3 to 4. For people with full-blown cirrhosis it's 2. So we basically reduce your dose maybe to 8. The question is how much effectiveness are you getting out of that? I don't know. At 8, maybe you're getting a little bit. Maybe it's worth it. Maybe it's not. I don't have a great answer for that. But yeah, just know your actual contraindications to your drugs. So.
Preoperatively for TNA for severe obstructive sleep apnea, how do you identify those patients? Is there a workflow that works for you guys to know that this is a high-risk patient?
They're identified by the surgeons. Usually by the time they make it here, the way it works here, but typically by the time they make it to us, that's already been identified or it's not going to be identified. A lot of the common practice among our ENTs here is they don't do sleep studies unless they're trying to rule out sleep apnea. They use it as a rule-out measure. If they suspect sleep apnea, they just decide that it's cheaper and more effective just to go ahead and take their tonsils out and easier, rather than putting them in a sleep study for overnight, and it may not go well. And so in kids, they tend to not get a full severity diagnosis preoperatively. We'll know they have sleep apnea. That'll be on our pre-op. We'll know that from our pre-op evaluation. We just often don't know the severity. So it's that experimental setting, not the real world practice setting where we know people have severe sleep apnea because they're prospectively looking for that. But in the real world, we often don't know, especially in kids, and it's based upon the apnea-hypopnea index. That's what it was based on. But that's kind of an experimental thing. I just say in general, I eyeball it and reduce my dose. So I figure out whatever 0.1 was, and then I reduce it down to some even-ish number below that, but at least half. So, other questions?
You mentioned Intraoperative as being a good adjunct for a variety of things, including pain. In light of that graph, where it's like a peak of inflammation, I think at 4 days, has anyone looked at like giving another dose of Dex at like 48 hours, 72 hours at home, maybe oral?
I don't know.
I
don't know. It's a good question. I don't know. It would probably that's outpatient, very outpatient management, which historically is driven by the surgeons. So that would be something. It wouldn't be in the journals that I typically read. I mean, it may have been looked at. I don't know. I've never done the PubMed search, but it's probably in the ENT journals. It may actually work. But the anti-inflammatory effect from this big dose of Decadron lasts for a while. But yeah, maybe there would be role for another dose, day 4 or 5. I don't know. I don't know the answer to that. That's a good question though. Other stuff? Okay. All right.